मुकद्दस है और कोर्ट मेरा घर है और ये मेरे लिए किसी जन्नत से कम नहीं। हमारे भी कुछ ख्वाब हैं जिनकी ताबीर को हमें पाना है।
आइए इन बच्चों के ताबनाक मुस्तकबिल के लिए अपना हिस्सा डालिए। अपनी ज़कात, सदकात, खैरात और इमदाद कोर्ट को दीजिए।
UK number 0300 123 7774. Website court.org.uk.
Almarad Tiles. With over 70 stores nationwide, we are now open in Peterborough. Up to 50% discount offers now on. Largest selection of tiles. Full bathroom suites from only £189. Paint, LED lighting, laminate flooring from only £7.99. Over 1,000 designs of wallpaper in stock. We have everything you need. Come and visit us at 193 Fengate, Peterborough, PE1 5BH, or call us on 01733 34 58 47. Almarad Tiles, now open.
In the mood for some authentic Desi food? Try Desi Restaurant on Lincoln Road. Start your day right with our Desi breakfast. Every day from 7 a.m. to 1 p.m. Halva puri, channa, nihari, paya, paratha and omelette. Need a tasty lunch? Every day 1 to 4 p.m. we've got fast food, pizzas, kebab sandwiches, tandoori dishes, balti dishes, biryanis and much more. We're also open every evening 5 p.m. to 1 a.m. Try our Desi Tawa special or our fresh handi, 1 kg chicken or lamb on the bone, cooked to order. Eat in, take away or free delivery. Visit desirestaurant.co.uk to view the full menu and order online. 60-seat capacity and a private function room. Catering service also available. Desi Restaurant, 298 Lincoln Road, Peterborough, PE1 2ND. Call us now on 555 795.
Broadcasting 24 hours a day, 365 days a year. This is Salam Radio.
Assalamu alaikum. This is your very own Dr. Shabina Asad-Kiyum for the Body, Health and Mind Show on Salam Radio 106.2 FM. I hope that you've all had a productive week. I know that that time of the year has creeped in. Traditionally, that is known as SAD, which is seasonal affective disorder, and many of us are suffering from it. For me personally, it's been a really tough week. I have to share that with you listeners because of a massive change of role in my life with regards to my profession. And it has been very emotional. But one has to think of broader and brighter horizons, and coming here has indeed been fulfilling, and I'm connected to you all, so it's wonderful to have your company on tonight's show. Now, before I move on, I'd really like to give one special young man a shout out. His name is Faizan. He's probably listening in. I wanted to wish him a very happy birthday. He's a very special young boy, and he actually appeared on one of our Salam radio shows this week, and he is 12 years old. So Faizan Bitta, from myself and from everybody else on Salam radio, a very happy birthday to you, and may Allah subhanahu wa ta'ala reward you with happiness and a life that is fulfilled for everything that you ever wished for. It is wonderful to see our young people doing so well in the city. And honestly, it's been wonderful just today meeting with young girls at the City of Peterborough Academy, and I want to give them a shout out as well because they are wonderful, articulate, intelligent young girls who have been really working hard at what they want to achieve. And next, what I did promise a little girl was that I'm going to give her a shout out. She's Aliyah, and it was her birthday, and I did promise her that I would give her a shout out, and I can see a heart being made there from Sister Michelle, our wonderful Salam radio station manager. Aliyah, I really hope that you had a beautiful sparkly birthday, just like your beautiful sparkly self. And this is from your Auntie Shabina on Salam Radio, the Body, Health and Mind show. Well, without further ado, it's a pleasure to have you all. It'd be wonderful if you could join me on this really important show. This is a really important topic, and the reason why it's an important topic is that there is a lot of stigma that surrounds this topic, especially within ethnic minority communities. I've got an absolutely wonderful guest, and she deserves a shout out as well, really, because we've had to cancel the show twice and she's been very accommodating towards us. But I'm going to introduce her first and then welcome on the show. So, ladies and gentlemen, we have Dr. Miss Afsheen Malik, MBBS, MRCOG. She's a consultant obstetrician and gynaecologist at the Heart of England NHS Foundation Trust. She completed her MBBS at King Edward Medical College, which is in Lahore, Pakistan, and she was appointed as a consultant at the Heart of England NHS Trust in October 2016. So she practices obstetrics and ambulatory gynaecology, and it's absolutely wonderful to have her in. She's also, her lead roles are that she's the lead obstetrician for perinatal mental health for the University Hospitals of Birmingham Foundation NHS Trust, the lead for undergraduate medical education at GHH. She's the lead consultant for junior doctors Rota at Good Hope Hospital. Her other main interests are high risk pregnancy care, intrapartum care, undergraduate and junior doctor teaching and training. And in today's show, we're going to talk exactly about that, about perinatal mental health. Miss Afsheen Malik, Assalamu alaikum.
Walaikum salam, Shabina. Thank you so much. It's a very explicit introduction you've given. Thank you very much.
Of course, and it's something that is worthy of someone like yourself. And, you know, I really want to thank you because we have been toing and froing a lot with this show. And sometimes meetings would come or guests had already been prearranged. And I felt really quite embarrassed. But thank you so much, because the life of an obstetrician and gynaecologist is a very busy one, isn't it?
It is very busy indeed, but I think you are very special. You're doing a really special job as well. So we have to be accommodating in whatever I could do. So I've tried to, and it's a really big honor for me to be here with you yet again. So thank you very much for inviting me to your lovely show, Shabina.
Thank you so much. So let's start off by talking about the stigma of mental health in itself and what actually led you to go into this field in your very, very busy line of work.
Yeah, I mean, nobody's actually asked me this question apart from, actually, to be honest, among the medical professionals, apart from a few patients. I suffered myself quite bad postnatal depression after I had my son. That's 14 years ago, when I was a mere first year SHO. Having no, background knowledge about what exactly it is, but I was so unwell, and I remember crying and not being, it was probably a textbook story, not going out, trying to sort of like stay in bed, not looking after the baby and all that. And I think as I grew in profession, there comes a stage in the life of a trainee that you have to pick and choose your specialities or subspecialties, as we call that. I think perinatal mental health was something that was extremely close to my heart. And I've seen a lot of our friends and families who've suffered in silence, because exactly due to the same thing, what will people say? Oh my God, you can't cope with the baby. And oh, you're crying always, such a happy time. And I think my heart goes out to all those women, our friends and families and all those in our community. Who've suffered through these things. So yes, like my personal experience and some of our close friends who've suffered with this, to be honest.
Yes, and I always put my hands up. I think you'll remember in our last show that we had, which was a while ago now, that I very openly say that I suffered from postnatal depression in my pregnancy, but it wasn't something that I identified very easily. And it was only when I was handed a questionnaire out by a health visitor that I ticked a lot of the boxes, and I looked down and she looked at it and she looked at me and said, "You poor thing." And I burst into tears. I didn't know why. And she said, "Okay, you need help." And it was from there on that I took the offer of the help that was given to me. And I've never looked back, and I've never felt ashamed of admitting that I was on treatment for 6 months. But your experiences do actually make you into the person that you are today. And it's so important to accept that you are feeling a certain way, and for people around you, especially your close ones, to register how you're feeling, because without that empathy, it's very difficult, and a person can feel very isolated when they're alone in that environment.
Very true. I think it's the passion, it's the empathy you develop towards your patient as to, already what they are going through. And also the passion, because you need to, I think, do the job that you love and you enjoy and you're good at. So I think it's a combination of all these factors. And I absolutely enjoy my perinatal mental health clinics. And I think since the last time we talked, since then we've established joint perinatal mental health clinics in our trust, where we see jointly patients together with obstetricians and psychiatrists and the whole team's input. And we've had extremely good feedback. So I think, and that has helped to remove the stigma associated, because no matter which, the stigma is probably more in, Black ethnic minorities, Asian minorities. But to be honest, Shabina, it's all across as well. I see all sorts of women from backgrounds and ethnicities where, mental health illnesses are not quite registered very well, and taking a tablet or a medication is still considered to be a taboo. So we really need to work. There's a lot of work that needs to be done to remove that stigma and to open up, the ways where the patients don't feel embarrassed about, talking about that.
How common is this problem, the problem of a mental health condition in pregnancy and just after giving birth?
So, so mental health illnesses, I think that's a really broad subject. It's a really broad thing as well. So I think if we talk about general prevalence, to be honest, in our trust, we had 1 in 5 women who were referred to an antenatal clinic with one or another type of mental health illnesses. Obviously, they differ in different kind of grades or spectrum, if you call that. So mild or moderate or severe. So we could have severe mental illnesses like schizophrenia, bipolar, or schizoaffective disorders, or something quite mild in terms of anxiety and depression as well. So overall, generally, yes, anxiety and depression is the commonest disorder. And over the years, I think a new component which we are currently quite working, a big amount of project is going on, we're doing in terms of birth trauma and post-traumatic stress disorder after having a difficult birth or a difficult delivery. So there's a lot of work going on about that nationally and within our trust as well.
Okay, well, that sounds really encouraging. And obviously, there's a lot of, we said that we would talk a little bit about post-traumatic stress disorder. How does this happen to arise in pregnancy?
Yeah. So I think if you talk about PTSD, I think for our listeners, just to keep it easy and simple to understand, there could be some things which are pre-existing from before the pregnancy as well. And to name that, I see a huge proportion of young women and young girls in my antenatal clinic who've had some sort of childhood abuse, whether it's a difficult childhood with neglect or physical abuse or sexual abuse. I think that's the biggest component which leads to PTSD when it comes to pregnancy, with internal examinations, labor, and fear of going through the childbirth. And then second big category is childbirth trauma itself.
Right.
And Shabina, you can and I can, I'm sure lots of our listeners who are moms or have gone through pregnancy, we all have like little expectations of how we want our labor to be. But things sometimes don't quite turn out to be the way it is. And I think it can be a really big shock if any emergency intervention is done. For example, an emergency cesarean section or an instrumental delivery, or the baby needs admission to special care unit. So I think all those kind of events can be quite frightening for the parent parents, for the couple as such, and for the family. So I think that could be one of the reasons for the birth trauma and in the subsequent pregnancy as well.
Yes, it can be. And people, actually, births vary, don't they, Afsheen? Births vary from woman to woman, the length of the delivery, the trauma that she goes through physically, and obviously physically that you have the pain element there. It's a pain that nobody can comprehend, really. And some births can be... I've always had, with my first, I had a precipitate birth, and I didn't realize how traumatic it was going to be, because you literally feel that the amount of pain that you go through bringing a child into this world, it's almost as if you live that trauma, you live it, and you see your child and you bond with that child. In most instances, mothers bond with children, but you feel extremely vulnerable as well. And because you feel vulnerable, sorry, Miss Afsheen, Dr. Afsheen, we've got somebody on the phone. I'm just going to put them on and introduce them. Assalamu alaikum, this is Dr. Shabina on the Body Health and Mind Show. You are live. Would you like to introduce yourself, please?
Yes, hi, my name is Dr. Salam. I'm a GP working in the Birmingham area.
Assalamu alaikum, Dr. Salam. Thank you very much for joining us. What would you like to say?
So I just wanted to ask Dr. Mehboob a question. So in our practice, we see a lot of ladies who've come in after postpartum depression, and they're going through a very tough time. Is there any new approaches or therapies which can help them, non-pharmacological basically, which can help get back on track as soon as possible, because obviously they're raising a new family? Is there any other options at the moment? Because not all, especially from Asian background, they're very reluctant of starting antidepressants. So is there anything we can do to help
face that stigma? Is that the real question, Dr. Salam? Okay, I think, Dr. Salam, are you still on air with us?
Yes,
okay.
Yes, I am.
So, Miss Afsheen, Dr. Salam is asking that a lot of stigma surrounding, obviously, taking of antidepressants with ladies that have just given birth. So how do we address that particular category of patients?
I think really valid question, especially he's from Birmingham, so I can relate to that because my practice is from Birmingham Heartlands and Good Hope, so that's all the community that we deal with, a huge a number of Asian women, and I can totally agree with that women are so reluctant in taking any antidepressants, doesn't matter how hard they need it. So I think my first form is always to go with psychotherapies, and counseling is always a mainstay. And I think, to be honest, even if you're starting antidepressants, they work very well if you do it in a combination with counseling and psychotherapies. So within the Birmingham area, within our trust, we are quite lucky. We have a really good team, like extended community networks and specialist mental health midwives, and provide services even for postnatal women up to 12 weeks after delivery as well. So usually, to begin with, we see them if they are on a severe mental illness spectrum, for example, postpartum psychosis or postpartum severe depression. Then we usually see them in a joint clinic to begin with, and from there onwards, a psychologist has their input. Then we have some help from different mental health groups, which involve the moms along with the babies and the whole families all together. So essentially, it's different type of psychotherapies and counseling to begin with medication as a second line.
Okay, I hope that answers your question, Dr. Salam. Do you have anything else to say?
Yeah, thank you. Just wanted to clarify, when you say joint care, is that joint care with obs and gynae and psychiatry?
Yes, absolutely. So obstetricians are not the gynecologist. So you need an obstetrician and and a psychiatrist, and you also have a psychologist, which is a very important core member of the team.
I see. That's really good, because if there's where there's an obstetrician involved, then they can obviously relate to what's going, because psychiatrist alone would be able to fully understand what's going on in the background, because I'm sure they're good with their field, but if there's a joint approach, then I think there's more chance of success.
Absolutely. You're absolutely right. Thank you. Thank you for the question.
Thank you very much.
Thank you very much, Dr. Salam. It was good to have you on air. Thank you.
Thank you. Bye-bye.
Bye-bye. So, Dr. Afsheen, put some very valid points up regarding depression and how to deal with it in the community. Talking again about the post-traumatic stress disorder element, we've spoken about how it comes about during pregnancy and during delivery. And within the UK, is it commonplace?
Yes, the incidence is rising, Shabina. I think if you look at stats, I was looking up the statistics in particular. So I found different papers with incidence relating anywhere between 3% to 16%. So it's a little sort of like a quite broad range as such. As low as 3% to as high as 16%. So it seems like a really small number, but if you remember, over 1 million babies are born every day over a year in UK. So that's quite a lot of, even 3% is quite a lot of moms who are going through or suffering through PTSD. And don't forget, that's a number which is recognized and is identified. And the main issue or the main next challenge for us as clinicians and obstetricians, and I'm sure as in the primary care as well, is to identify and recognize the PTSD, because there are a lot of women out there who don't even seek any help and don't ask for any help. So the numbers registered are only those which are identified.
I have a sort of a question from an anonymous person who has stated that they have recognized they lost their baby at a certain age of gestation and had bereavement support for 2 weeks, and further to that was advised to go for counselling, which really didn't work. Now, this young mother has obviously suffered a lot with regards to her emotional well-being. She's had a younger child to look after and losing her baby quite late in her gestation, and she's felt quite traumatized. She's got very little support and understanding by virtue of belonging to the ethnic minority community, and she was started on sertraline, which hasn't worked and has made her unwell. What would be the next step for such a patient?
So my advice would be, it depends upon the area where they're living in and what access they have to specialist mental health care, really. So first advice would be to go back to the GP. She's clearly not well. Sertraline, as I've said in the previous question as well, so medication on their own, they don't really work very well. You really need to have good support in terms of counseling, psychotherapy, and ongoing support as well. You just can't offer 1 or 2 sessions and then just stop at that time, which is what happens, looks like, happened to that lady, unfortunately. So I think go back to the GP, ask for another referral, which needs to be done quite immediately and urgently, because it seems like she's not very well. She's probably not taking sertraline because that's making her feel unwell. And she needs to have specialist care. Shabina, one of the really kind of big disadvantages we have in the mental health care across the regions is that it's very sporadic and it needs to be much better streamlined. So it's so much dependent upon the postcodes, and one woman might have excellent specialist mental health care, and the woman next door might not have anything. So we really need to work much towards that. And I think regionally I can always refer to Birmingham area because that's where I work in. So there is a huge project going on by the name of BUMP. Where we are trying to streamline the care pathways and the access to specialist mental health care, which we've got a lot of funding for that. So hopefully within the next 2 years, we've already come a long way since last 5 years, and we hope to achieve much better in the next few years as well.
Well, that sounds absolutely wonderful, especially for those patients that really need it. And I've got a listener here, Munir Ahmed, who's a regular listener of our show. Thank you so much for the loyalty towards the Body, Health and Mind show, Munir. And he has said that although this is common amongst the Asian community does not have any provisions in place. That is, to push this forward, to make this known that such services are there. Another issue is the language barrier, and most of the services are in English. That's my opinion. I could be wrong. You professionals would know of any such services. What is your take on that?
Absolutely, I agree with you, Munir. There is a lot of barrier in terms of the patient's reluctance, patients coming forward. And I think anybody who's actually got the courage to come up, either with or without family, we need to make sure we can talk to them in their language and make them feel comfortable as well. So I think with that regard, a language line is a really useful tool which we use. I use in my setting quite often. Face-to-face interpretation is excellent if you can get it, but language line is something which is readily available everywhere. And secondly, about written material, I tend to use the leaflets which can be translated into the local language. So again, in Birmingham we have Romanian, Somalian, so you name an ethnicity and a language. So we can translate those. So we have provision for the translation of the leaflets into their own local language, so the patients can take home and come back. And I usually tend to book a face-to-face interpreter for my clinic sessions, because that actually makes it much easier, talking to them, assessing their body language as well, and they can open and ask questions if they have any more freely.
Yes, and that's really important. In fact, I'm not sure what your take is on this, Afsheen, but there is a resource known as patient.co.uk, and it has a translate button at the top where the printer is, the printer icon. So and you can choose any language and it automatically defaults it to that language. And I often print out leaflets for my patients in their language, and the name of the web resource is known as patient.co.uk if you wanted to find out what to do. Now, with regards to post-traumatic stress disorder, I keep on going back to that because I don't know why it really is a subject that hits me when somebody feels traumatized, especially if they've become traumatized due to a prior event before giving birth. What would you say in terms of longevity of treatment should the period be for a person to undergo treatment to help them to look after their baby after they've given birth on the background of this post-traumatic stress disorder that they are diagnosed with?
Very practical question, Shabina. I think that's something which patients ask quite often as well. How long am I going to require the treatment? And the answer is it's very variable. It depends upon the initial aggravating trigger. It depends upon the personality. It depends upon the background, if the patient has got any pre-existing anxiety, depression, and how much support they have, compliance with the medications, so lots of factors. So as you can see, it can be so variable from patient to patient. I would say a minimum of 6 months is the first thing to begin with, and that's what I tell my patients as well. So you start off psychotherapy or counseling. The first line is usually cognitive behavioral therapy, so CBT. So CBT is usually for the first 6 months. It's regular sessions, once weekly or once in 2 weeks, depending upon how the initial symptoms are. It's usually associated with a lot of family support as well. So, for example, we have a very good charity, Acacia, which works quite together with the postnatal women in particular, providing them like play groups and support groups where the moms can, meet together. And that's quite important as well, because you'll see a lot of women with PTSD always have, not always, often have overlapping symptoms with depression as well.
That's right. So, sorry to bother you, Dr. Afsheen. 10 seconds to the break. We will come back and revisit this if that's okay with you. So,
absolutely.
Thank you. See you soon.
Stay tuned to Salam Radio after this short ad break.
It doesn't take much to bring some difference. You give some change, which makes a change. Because nothing gets mileage like a charity. Just a little change turns into a chain. And before we know it, the results are massive. So give a little to make a big difference. For donations, call now. UKIM 0207 387 2157.
Had a car accident or an accident at work? Accident specialists are experts in no-win, no-fee accident claims. Leave the hassle to us. Our multilingual settlement experts will manage the entire claims process on your behalf, with nothing to pay up front. We provide services such as credit hire, taxi vehicles, recovery, storage and much more. For full details on our range of services and a free consultation, call us on 01733 555 774 or visit our office at 249 Lincoln Road opposite the NatWest Bank. Accident Specialists. Start your successful claim today.
Do you own a restaurant or takeaway? Cater Fair is an expert supplier of new and used commercial catering equipment. Visit caterfair.co.uk for quality equipment on sale at the lowest prices, or call us on 01733 310 115 or visit us at 11 Royce Road, Fengate, Peterborough.
जब बात हो हलाल मीट की तो कैसे मुमकिन जिक्र न हो हाजी बाबा का। हाजी बाबा अज़दा में आपके लिए। हम अज़दा में अरसा 10 साल से जायद मुल्क भर में 45 से जायद काउंटर्स के साथ बेहतरीन पैकेजेस, हर वैरायटी का मीट और आला मायार के लिए आइए हमारे पास। चिकन ब्रेस्ट, चिकन क्यूब या कीमा सिर्फ 3.99 पाउंड पर केजी, लैम या शीप लेग, लैम शोल्डर और मिक्स सिर्फ 6.99 पाउंड पर केजी, बेबी चिकन सिर्फ 1.99 पाउंड पर केजी। आपकी सहूलत के लिए वक्त की बचत और मायार की जमानत, तमाम हलाल गोश्त और अशिया जरूरत एक ही छत के नीचे। हाजी बाबा हलाल मीट, फाइंड अस इन अज़दा।
Assalamu alaikum, Dr. Shabina here. Has your child had their flu vaccination this year? All primary school-aged children are entitled to the flu vaccine in their schools, helping to protect you and all the family against flu, which can make vulnerable people very ill. Call the school immunisations team on 0300 555 5055 if you'd like your child to get protected.
This is a Salam Radio management announcement. Please be advised that we will be off air for a short time on the morning of Thursday, the 23rd of January, as routine maintenance is carried out at our transmitter site. We will do our utmost to return to our services as soon as we are able and continue delivering great content across the city. During this time, you can still tune in online at salamradio.co.uk or alternatively catch one of our repeat live shows on Facebook, YouTube or Twitter. Thank you for your patience and your continued support. Jazakallah khairan.
Bismillah. قال النبي صلى الله عليه وسلم الدعاء مخ العبادة. The supplication is the essence of worship.
Broadcasting 24 hours a day, 365 days a year. This is Salam Radio.
Assalamu alaikum, welcome back. This is Dr. Shabina for the Body Health and Mind Show on Salam Radio 106.2 FM. And we have the wonderful Miss Afsheen Malik. That's the right way to say it, isn't it? Because you're surgeons, so it would be a Miss Afsheen Malik, wouldn't it?
Yes, Shabina, absolutely right. You can call me Afsheen, but yes, essentially, if you are a surgeon or surgical specialty, it's a Miss or a Mister.
Yes, because I'm married to a Mister. That's why I know. And I put my hands up despite being a GP and despite doing surgery as well, or being, I would say, an ex-surgeon. I was a very good one as well, but there you go. And despite all of that, I've always been confused because with obstetrics and gynaecology, there's a lot of physical medicine involved too. But you are surgeons, so you have every right to be called Miss. So it's good that you've clarified that. So thank you for that. And just for my listeners that have come back, it's wonderful to have you tune in to this really important show. And it's such a popular show at this moment in time. We have so many questions coming through, which means that it's one that has served its purpose because we are trying to eliminate the stigma associated with mental health and pregnancy. And the period after that in terms of the antenatal and the perinatal and postnatal period. So I have here Miss Afsheen Malik, who's a consultant obstetrician and gynaecologist at the Heart of England NHS Foundation Trust, and she practices obstetrics and ambulatory gynaecology and is the clinical lead for perinatal mental health in her trust. So the questions that I have here are from a brother, Imran Ilahi. What is the difference between PTSD and PND, so post-traumatic stress disorder and postnatal depression?
Very intelligent question. I mean, that's a really clinical dilemma as well. As you might have encountered yourself, Shabina, in primary care, it can be so difficult to differentiate sometimes whether it's PTSD primarily or whether it's postnatal depression. For our listeners, just to clarify, postnatal depression is obviously a type of depression which occurs after the delivery of the baby. And it's not something to be confused. I'd like to clarify about the postnatal blues, because that's something that happens more naturally due to the change in the hormones related to the pregnancy and the delivery. Lasts only for a couple of days. However, if you are as a patient feeling low mood or losing interest in your usual day-to-day activities, which used to be a pleasure to do before, there's loss of appetite, loss of sleep, tearfulness, I think lasting for at least a couple of weeks after the delivery of the baby, that could be one of the signs of postnatal depression. With PTSD, it's generally you can go down and you can usually locate a trigger factor. And as a doctor, I always use history as my biggest tool. And that's the advice for all the medical students and all the doctors wanting to be doctors as well. Use your history as the biggest tool. And when you take a really good detailed history, you can always go down and figure out there's usually a trigger event. And although if there are some sort of like 30 to 40% overlap of symptoms between PTSD and postnatal depression, but using specialist questionnaires and face-to-face a good history taking, good communication, we can reach a diagnosis.
Right. And I think that that's really put it out in a structural context as to what the difference between the two are. I hope, brother, that has answered your question. I have another comment here from Munir Ahmed. I came across a couple in court as I'm interpreter. I was engaged for one of the parties, and what I was told by the husband was that after the birth of the second child, the woman became mentally ill. Obviously, it must have been post-traumatic stress disorder, which was not recognised and treated, which led to her mental health issues, and hence it led to divorce. Don't the doctors or hospital have any kind of examination in place after the birth of a child to ensure the woman is mentally coping and managing and everything is okay?
Very sad story, actually, isn't it? Yes. In essence, the answer is yes, there is, and once it can be if the features, if the woman has symptoms which are very subtle, then it could be quite hard to pick up. However, if the woman is sort of like showing signs of I would say more like psychosis, not feeling well in herself, showing any kind of violent features or features of self-harm or intrusive thoughts or something like that. I think that could be much easier to pick up. And even, any woman who's after delivery, even after a straightforward delivery, stays in hospital for at least a minimum of 6 hours. That's like a minimum rule all across the country, and can only be discharged upon satisfactory checkups by the midwife. And that includes not just the physical examination, but also the mental health examination. If the woman previously fit, well, no mental illnesses is deemed any change in the mental status, not having, for example, mental capacity or not having the capacity to look after the baby, there's lots of processes in place to make sure that the mum and the babies are safe before sending home.
And it's really important that you say that. My own personal view, obviously, I've got nothing to substantiate it, but because of the pressures on the NHS, which isn't in nobody's control, I do find often that because of the very speedy discharge and high turnover, because of the lack of beds and demand in population, we often a woman is quite overwhelmed, and there's a lot of changes that are going through her body and mind when she gives birth, which makes it difficult to assess whether she really is in a position to go home, because sometimes a lot of those feelings of depression settle in much later, don't they?
Absolutely. I think there is no denial to that. I mean, NHS is under crisis. I mean, there's junior doctors shortage, there's staff shortage, there's beds shortage, and particularly winter season, there's so much pressure from the management to discharge patients as quickly as we can. However, at the end of the day, as a clinician, I always take, I think, as any clinician, not just me, I think we, as a clinician, the foremost priority is to make sure your patients are safe, and one other important thing which I think is quite useful, and I always teach my juniors and the medical students as well on the ward, to use a hot debrief. So anybody on postnatal ward, when you're doing the ward round, if you see anybody who's had a venous delivery, a forceps, a heavy bleeding, infection, high blood pressure, anything which is not just out of a part of the normal pregnancy, use 5 minutes to debrief. Go through the history, go through what has happened, what were the events, why we had to intervene, why, what, if the pain relief wasn't that good, if she had any complaints, why the baby had to be admitted to the special care. Because remember, mom can't bond quite readily with the baby as well if any of these things have happened. So take 5 minutes to go through the notes, figure out what has happened, explain to the woman, explain to the partner. And if they have any questions, immediately we should try to answer them. I think that alleviates a lot of anxiety, because remember, as a doctor, we're always in the time of an emergency. If the baby's heartbeat is going down and we're trying to deliver the baby, obviously we are trying our best to save the mom and the baby. But if you look at it from the couple's point of view or the patient's point of view, there is a lot going on. She wasn't expecting an emergency bell to go off, or a lot of people to, sort of like storm into the room, and so a lot is going on. That can be quite frightening for any person at all. So please use this 5 minutes, I think, to debrief. And for more severe, more complicated patients, it's always good practice to bring them back. 6 to 12 weeks later, even in primary care, the patients can be referred back. If as a GP you think that this patient needs a little bit more counseling, please book them under a consultant for a 12 weeks later postnatal debrief session, where the consultant can go through all the events through delivery and investigations that were required. And please don't forget about Shabina, the impact on the future pregnancies as well. So if somebody who's had a gestational diabetes or a high blood pressure during this pregnancy, use this time, the debrief postnatally, to discuss how the next pregnancy should be planned, and postnatal contraception as well, of course. So these little things, they are so important, and they go a long way when you see these patients afterwards. So I think it's good from the trust clinical governance point of view, and it's so satisfying for the patient and for the doctor as well, as a clinician.
Very well put and very well articulated, Afsheen. I've got another question from Brother Imran Ilahi, who says, another one, how can we help if we suspect someone in our family is suffering from this condition?
How you can help, I think, again, first thing would be to refer to your GP. Primary care is always the start, and a GP can usually pick up what kind of diagnosis, the severity of the spectrum of PTSD as well, what was the initial trigger, and mainstay of therapy for PTSD is usually CBT or counseling to begin with. If there are any overlapping symptoms of anxiety or depression, medication could also be started as well. And then from there onwards, if needs be, any specialist referrals to psychologist or psychiatrist could also be made. And I think from the brother's point of view, I'm not sure if there is any family member. I think what you can do as a family member is to give them as much support as you can. Don't be judgmental. Don't try to be label that person having a mental illness and all that. I mean, I always say, if a diabetic, if you have diabetes, you take medication without any problems, and people actually encourage you, make sure that you take your medication on time. Same thing is with mental illnesses as well. So please don't be judgmental to your friends and families who are going through a difficult time. Try to support them, try to make their life easier.
I think that's so well put. And talking of the family, I see many patients who come from a combined family system. I think people forget that when a woman gives birth, there's so much change that she's going through, whilst at the same time losing her sleep because she has a newborn baby who is fully dependent upon her. In our societies, in our communities, in our setups, I know certainly with my own personal experience, I would have appreciated a little bit more of personal time and privacy and help as well. That's not always the case, Afsheen. So what can the family do in a combined family system scenario to support a daughter-in-law who has just recently given birth and she doesn't feel too good emotionally?
Yeah. I've recently, I'm going to use an example here, Shabina. I've recently seen a patient, a very well educated, trying to be anonymous, not using a very well educated patient, a working woman, and she lives, after, so Asian ethnic minority background. And living in a joint family system with a mother-in-law. And I was so impressed because every time I've seen her in the joint clinic, she was all full of praise for her mother-in-law, because she was so understanding, and she was giving her extra support. And this patient particularly had a severe mental illness, for many years on medication, so requiring a lot of input from obstetricians and psychiatrists and like the full team. So I think this is a really good example that this is doable and we can do it. Personal space is something that everyone needs. You need that little bit of personal space even between a couple as well. So I think especially when you've had a baby, it's a really vulnerable time. Woman is going through a lot physically, a lot mentally as well, trying to adjust with the husband, with the baby, as you said, with sleep as well. So I think, yes, you do need to be around, you need to be available, but giving them their own space as well as a couple or as new parents to adjust into their routine. By all means, making sure that, they have like good breaks, taking care of the baby on and off so they can mom can have a quick nap, or helping with cooking food, or, sort of like household chores so she can actually concentrate more on the baby. I think that's much appreciated, rather than taking over the baby. I think that's another thing which I've seen quite often in Asian communities. The grandmoms and granddads, they are so enthusiastic. Not to blame them, but they always want to take over the baby, and that's not something that a new mom wants you to do. So in a most gentlest and the most respectable way, I think you need to give new moms and dads a little bit more space, but being supportive and being there for them as much as you can be.
There are some setups whereby ladies who have given birth go to their parents' house for a convalescence period so that they are supported. Obviously, that takes away the whole sort of environment in which the baby is then going to come back to, and then she starts all over again. But would you suggest, with regards to other things like visitors, for example, visiting, and there's a lot of expectation in that regard, and somebody sent me this question because they probably want us to serve as that voice, that in the initial days, is it more better to limit the amount of social visiting that takes place, or should one be encouraging of it?
Absolutely. There's no two ways about it. I'm absolutely, so much in favor of having ever said, a personal space, private space, let them settle into. It's so important, again, first of all, as you mentioned about going into the mom's home, I think that's a really bad idea. I might be really, I don't know how to put it, I might be quite sort of like uptight about it, but I think the dad kind of loses out of this thing, because traditionally if the girl, the mother, sort of a new mother, goes into their parents' house, the bonding of the dad. So remember, partners are always there as well. And we talk about PTSD to moms. Partners are quite often affected by that as well, because remember, they're always a birth partner in the room, and that's usually often the partner or the husband. So the dad loses out on the bonding with the baby in the first few weeks, and so first few days later, when the lady, with the mother woman comes back to the partners or the in-laws home, she's already settled into a routine, and there's no place for the dad. So I think it's kind of an unbalanced kind of equation, really, as a family altogether. Sorry, what was the second part of the question, Shabina?
So you did actually answer it with regards to the visitors coming,
yes,
coming
visitors
around, and the social aspect. Sometimes, though, invariably, young women have found that they have to meet a certain kind of expectation and would feel judged afterwards if they're not in the right frame of mind to sit with guests, for example. And I certainly got it, that when my children were born, even though I was in my own house and I was being supported by my husband no end, but I would always be told that these people are coming to share in your happiness, and we should be welcoming, which is great, but it doesn't always impinge positively on the woman going through it.
Can't agree more, Shabina. I think that's a feeling I think with most of us have experienced, but I think going forward, if we've gone through that, doesn't mean that our younger generations has to go through that as well. So we could be somebody who could bring the change, to be honest. And yes, visitation, yes, the women people want to come in, and it's really good that they want to come and share the happiness with you. But maybe you could limit like the evenings or afternoons or something, a time sort of like maybe like few hours in the evening, so the mom can have some a nap in the afternoon or have some rest as well. You can't really be bothering a new parent all the time. You have to be quite wary of the fact that the baby has no hours of sleeping or getting up or waking up and all those, and again they're trying to settle in their new routine. So please everybody try to be a bit more vigilant of when you are visiting, and do you really need to visit at that early? Maybe give them a few weeks before they've settled into 6 to 8 weeks or something. I think is a good time. And I think being judgmental, that's quite important as well. So I think physical appearance, there's a huge I'm sorry, I'm adding into this thing as well, just because it's a really sensitive topic.
It's good that you are.
And after delivery, oh, she's so fat, oh, she's put on so weight as well. So I think a new mom is not ready to hear all those kind of things as well. So I think just leaving them a few weeks, and then you can always see them later on. The baby's not going anywhere, the mom's not going anywhere, the family is very much there. So just give them some time to be themselves again. Phone has made life so much easier. You can always talk over the phone. Just make sure so the parents knows that if they need, there's somebody there they can call for help, but not just invading their own private space.
That's absolutely right. And the actual fact that you comment on the judgment of people to say that she's put on so much weight, you're looking sloppy. Sometimes, even now, after 4 children, I would wake up in the morning and say, I just don't feel like changing at all. There have been times, even over the Christmas period, where I've thought, oh yeah, I don't even want to brush my teeth. But that's okay. And people have to be made to feel comfortable in not meeting a certain expectation. I know sometimes it can be difficult in our cultural setups, but it is essential for a woman to feel stable in her emotional well-being, for everything else around her and associated with her to function in the right manner. And I'm sure that you would agree with that.
I absolutely agree with that, Shabina. I don't know. I mean, it's where does this pressure comes from? I mean, there's always this ultimate pressure to be the ideal or the perfect woman all the time. You have to be good looking, you have to be a really mentally alert, a really good mom, you have to go out, bring some money home as well, you have to look absolute alert and lovely every time either you're going out or you wake up in the morning. I think these are all the pressures that we have created for our own self, really, and this is I mean, that's a taboo that we have to break, to be honest, at some time. I mean, I don't believe in anything like that, and that's part of my essential counseling in any woman, I see postnatally, or even sometimes antenatally as well, for a group of patients. They should not and cannot let anybody else judge what they are, who they are, why they are taking medicines, why they are, going to the hospital for mental health appointments and all that. It's their life, and they should have the full control. That's part of what we call as modern day slavery as well, isn't it? I mean, where the woman cannot do anything or feels reluctant to even come to the hospital appointment. So we've started joint clinics where the obstetrician and the psychiatrist will see the patients together. And believe it or not, our DNA rate for the mental health clinics has gone down by 30 to 40%. So that's a massive drop. Why? Because patients don't want to come for the psychiatric only mental health clinics only. They prefer, or they want to actually show to their family that they're going for an obstetric visit, and that's very well accepted. But a mental health checkup is not well accepted. So, these kind of things, there's a lot of work that has been done, but I think we are a long way away from what needs to be done as the standard.
I think you're absolutely right, and it's about creating awareness and educating people and trying to make the world a more kinder place. Now, in the last 4 minutes of this show, Afsheen, somebody has asked, how long should an individual, if placed on antidepressant medication, how long should they remain on it for initially, if they are placed on it in the event of postnatal depression?
Okay. So I think it depends upon what medication they are on and what is the severity of the spectrum, what kind of, help they've got in the background as well.
Yeah.
If you've started only on a baseline dose, usually citalopram or sertraline seems to be the most commonest ones to use during or after pregnancy. So if they're only on the first sort of like lowest dose, then maybe I would say 6 months minimum being stable. So if you've had an incident which made you unwell and you've started medication today, I would not change the dose for at least 6 months, provided you're stable. And after 6 months, I would consider bringing it down, or slowly and gradually. Again, a very important thing is, you cannot or you should not stop these medications abruptly because of the side effects and, how it makes you feel. Yeah. However, if you're on a slightly higher dose, then at least 6 months on the first step. So if you're 100 milligrams of sertraline, I'm using an example here, then 6 months later, if you're all well, no concerns at all, I would bring it down to 50 milligrams. And then 6 months later, I'd consider stopping it if you've remained well during that 1 year of period. I hope it makes a little bit of sense to the person.
Of course. I hope that has answered that question. Now, it's coming to the end of the show, Afsheen, and I ask all of my guests to give one golden nugget of information to our listeners so that they can take that away with them today, if they're listening.
I think I'm really passionate about perinatal mental health. I can talk about these topics for days and hours, but I think one thing through your show to all the listeners is, please do not be judgmental. Please try to support anybody around you, your friends, your family members, workers, colleagues, anybody who's going through any mental health illness. Please be supportive. Try to help them and try to make their life easier by being a good, empathetic person.
I think that's such a wonderful way to end the show. And in the last 60 seconds, Afsheen, thank you so much for coming on the show and addressing something which is a bit of a taboo issue. I'm so grateful to you. I really am, for your wonderful, valuable time and for the wonderful service that you provide to the NHS. This show has been an absolute hit. We've had so much listenership, and you will see the interaction, hopefully, because now you're famous, and you will see the interaction. And the interaction has been generated by men. It's been wonderful, the interaction that men have shown, and I really do applaud that.
Well, thank you, Shabina. We're doing a lot of work for birth trauma, making the referral pathways and management much more streamlined. So hopefully when we meet again next time, I'll update you on that. And starting a new clinic, which is a joint one for patients just for who've had PTSD with birth trauma.
Wonderful.
That's starting next month.
Thank you very much. And
Stay tuned to Salam Radio after this short ad break.